afternoon, everybody, and welcome to this Insight session. I hope you're all enjoying this year's conference as much as we're enjoying bringing it to you. My name is Suhaila Mohammed. I'm an occupational therapist and I work here at the Royal College of Occupational Therapists as Head of Practice and Workforce. Today's session is all about primary care. We're going to hear from a phenomenal group of occupational therapists in Wales and Scotland who are making strides with pride and leading the charge to integrate occupational therapy in primary care services. We'll hear what motivated these occupational therapy leaders to work in primary care. We'll hear about the things that enabled their successes, and we'll also learn from the things that got in the way and what they did to overcome those stumbling blocks. So let's get this show on the road and meet our brilliant panelists, and we'll meet them one by one, starting with an introduction from Shonaid.
Hi, Suhaila. Thanks, everybody. My name is Shonaid McCabe. I'm the occupational therapy care lead for primary care in Lanarkshire up in Scotland.
Brilliant. Thank you, Shonaid, and welcome. Next, we've got Alex.
Hi, I'm Alex Gigg. I'm the lead occupational therapist in primary care within Swansea Bay University Health Board, and I also am chair of the All Wales Network for Primary Care OTs.
Very warm welcome to you, Alex. And next we have Alexis.
Hi, I'm Alexis. I'm a clinical lead occupational therapist in North Wales, and I'm a lead for mental health and learning disability at the moment, but I have worked in primary care and I'm doing some projects in primary care as well.
Awesome. Great to have you with us, Alexis. And last but certainly not least, we have Di.
Yeah, pronounced Dar, everyone. I'm Davies. I'm an occupational therapist and I'm employee of the Royal College of Occupational Therapists as the professional practice lead for Wales.
Amazing. Thank you. And thank you all for joining us for what I know will be a stimulating and inspiring conversation. So please do keep your questions and comments coming through the chat, people. We've got Genevieve Smythe, one of RCOT's brilliant professional advisors, on hand to help. And thank you, Jen. So let's get into it. And I want to start with a question that takes us to the very beginning of your journeys in primary care. And Alexis, I'm going to come to you first. How did it all start for you, Alexis? Why did you develop services in primary care?
I think the why reason, I'm going to give a really simple answer. It's because it's the right thing to do as far as I'm concerned. So I think occupational therapists are self-management professionals, and I don't understand why we put self-management at the end of people's journeys through healthcare. I think it should be embedded right from the beginning.
Yeah, I absolutely agree with you there, Alexis. Thank you. Next, I'll come to Shonaid, please. What was the motivators for you, Shonaid, to start on this journey, please?
Okay. I think, like Alexis, it was the right thing to do. I suppose what happened for us in Lanarkshire was there was an opportunity, because often you need an opportunity to let things happen. So in Scotland, we had the GMS contract, and with that brought a lot of discussion around primary care redesign. We weren't originally at the table for those discussions, but our professional lead, Janice McClyment, very much got around that table. And we got into discussions about how can we do things differently in primary care, and this shift towards earlier intervention prevention and additional professional roles. We really saw the opportunity to make occupational therapy much more accessible, as Alexis said there, about earlier people's journey rather than where occupational therapy perhaps traditionally sat. And so with that primary care transformation arena, I suppose we managed to get our foot in the door, and albeit a very small start, 2 part-time OTs, 2 GP surgeries. That was where we started in 2017.
Really strong motivator there to make occupational therapy services accessible to all. Thank you, Shonaid. Di, I wonder for you, how did it all begin for you on your primary care journey?
Yeah, so obviously I'm in relation to policy, so the door was opened by policy in Wales and throughout the rest of the United Kingdom. And one of the first places I visited was Alex's service in Aberdare, as it was then, and it demonstrated by the lived experience the absolute power that we give to primary care. So Alex is the lead from Alex's GP surgery sort of said to us, actually OT is like a mini MDT in the service. He couldn't quite believe how great OT was. So it's almost it's like, I mean, we can demonstrate our effectiveness once we get into GP practices, and then it's snowballed in Wales. Then once one doctor talked to an next cluster, I mean, it snowballed then. So once we get in, we stay in and we expand, which is really, really good.
Yeah, love that, Di. Thank you. Absolutely important to mention the political drivers for this, to move services more into the community with a focus on prevention, but absolutely that seeing it to believe it piece. So thank you, Di, for bringing that to our attention. Alex, for you, how did it all start?
I think another simple answer really is the why not? Why not just do it? We just had a really great opportunity in 2017 in my previous employer, Cwmtaf, Morgannwg, which is fantastic, really, as Di was saying, to get embedded within this virtual ward model that they had going on. It was a very small MDT of a GP, a business partner, care and repair, third sector, and a pharmacist at the time. Okay. And they just felt they had this missing skill set that OT could meet. And our head of OT at the time was really great at kind of advocating for that and getting that foot in the door, really, and seeking that funding stream. So I went in April 2017 to do that pilot, mainly looking at tackling that chronic condition frailty side of things in the community. And for me, it just felt like the perfect OT role. It allowed me to use the full breadth of those OT skills, demonstrate, I guess, in an arena that weren't used to the information that we were providing. And it just grew from there, really. As soon as I was in, I just knew that was the place for me to be.
Amazing. And as you're talking there about that breadth of multi-professional skill sets, Alex, I was struck by, I guess, the relevance and applicability to virtual wards too. Is that something that you found?
Yeah, absolutely. I mean, the OT role is much broader than just virtual wards. And I think that was one thing that was really key when I went in, that they saw this skill set missing from the MDT that connected the health condition to kind of how someone was living with it and the struggles and the strains and the difficulties that they were having for these people that were still attending the practice, yet weren't necessarily needing any medical intervention anymore.
Yeah.
So it quickly grew out of, I was there for a virtual ward, but actually then that probably only became about 30% of the caseload that we saw. Cwmtaf evolved and it became more of a virtual ward model over time just because of the way staff was structured. And in Swansea Bay, it's a bit similar, where our core team is probably more virtual ward and we've got a smaller input into kind of the clusters. But I still massively believe in how important it is to be embedded with our GP practices rather than just aligned.
Okay, awesome. Thank you so much. And thank you all for sharing, I guess, your motivators and where the idea began, if you like. Alex, I'm going to stick with you, if I may, really just to try to unpick the development of the vision that you had for occupational therapy in primary care. And I'm particularly interested in that process of developing the vision, but also how you managed to get the buy-in from the people around you. How did you achieve that change of hearts and minds?
Good question. I'm a little bit of a fly by the seat of my pants type of person, I gotta be honest.
Love it.
So I didn't necessarily do a lot of planning going in. My first day into the practice, I remember the practice manager saying, "Yep, great to have you, but what are you going to do for us?" And I learned very quickly within that first hour or two that I didn't really have the time, or they weren't able to give me necessarily the time for me to explain the breadth of the OT skills. I needed to show them. So even on that first day, I basically said, okay, let's look at your frequent flyer list then. Those people that are coming back and forth regularly, or those people that maybe have high frailty scores with you. And from there, I was out seeing people on my second day, to be honest. I just thought, I need to show them in a different way. I need to give them different type of information that they weren't accessing, so that I can show them what we cover from a physical health and mental health, kind of all of those social questions that they're asking. And that we're giving them quite a unique set of information from our assessments and our interventions, really. That's kind of how I built that initial buy-in. And from that, it really did just snowball, because once you kind of build up that understanding of the OT role and the GPs being quite competitive with each other, and they get a sight of, oh, you're doing this in one practice, why aren't you doing it in ours as well?
Right.
that really helped, because actually, I think we've heard it in other talks, but once you engage and you get those allies on board, they do the majority of the promotion of your role for you. You're doing your data sets, and I had to do a lot of backward chaining, as I said, because I was flying by the seat of my pants to start with.
Yeah.
And for some people that won't work, and that's absolutely fine. But when you do it, and you get that engagement, and you realize that actually, when they really believe in what you're offering, and they can see it as a completely, totally unique and different skill set than anything that they've had in primary care before, then, like I said, they got access to all of these different forums that they go to, and they're saying, well, OT can do this and OT can do that. And that message I found was really great. So to create that vision, I think I did it through doing, and I did it through showing the breadth of the OT skills rather than trying to sit and explain it, because I just realized they just didn't have the time for me. They started making more time for me when they realized how I could benefit them. But in those initial stages, it was a bit more difficult. And then just lastly, from achieving full population coverage in my current role as well in Swansea Bay, that was a little bit easier, mainly because the senior responsible officer for our virtual ward, also deputy medical director, was already so engaged with OT just from the evidence base that had been created across the UK by this point, back a year and a half ago. And so much so that OT was the only AHP that was then invested in for their virtual ward model at the inception. And it's only now, nearly 2 years on, that they're starting to talk about the other AHPs coming in. So from that point of view, it's been brilliant.
Amazing. I've really taken from your answer there, Alex, the power of showing, not so much explaining, but absolutely showing. And it's not been missed, the power of doing, and of course the synergy there with occupational therapy and us as doers. Also really taken by this idea of building alliances and having alliances that do the advocacy and the promotion on our behalf. So thank you so much. Shonaid, I'm going to come to you next for an answer to this question about the development of your vision, and perhaps any tips or tricks to be able to change hearts and minds.
I think I'm going to echo a bit of what Alex said. We did have more time to think about our vision, what we wanted to offer. We had quite a bit of planning time, myself and Lisa, my colleague, at the and we talked about, how do we explain OT, what can we offer, what's our offer going to be. We work across mental health and physical health, so it's a very big offer. So it's around just identifying people whose functional ability is impaired for whatever reason. And I suppose we then distilled that, like Alex said, you don't have a lot of time to just explain that to the GPs. And we very quickly realised that we were going about it from the wrong angle. Instead of telling the GPs what we could do for them, we asked them what they needed help with. Pretty confident that it was the same thing, and thank goodness it was, because that would have been embarrassing if it hadn't been. But we knew anecdotally what they were struggling with was the sort of non-medical people, the people that they don't really know what more to offer. That doesn't respond to medicalisation. The GPs are very caring about these people. They know what they maybe perhaps need, but they don't have the skill set or the time to offer them. So by asking them, who are the people who you find difficult, not the people, but the things that you find difficult, the sort of things that you're presented with each day, you think, I don't have the skill set for that, I don't have the time for that, I think somebody can do it better. That was a much easier question and a much easier way, rather than us giving a big, this is what OT is, this is what we do. So that got them listening, that got them engaged. And then, like Alex just started doing, showing them, going back to them and showing them, this is what we did with this patient. You realise they're not coming back now. We've sort of sorted what was going on with them and that type of thing. And I think that was the crux of it. And again, as Alex said, once they saw that, once they realised what we're doing, they became our supporters. And actually, many of these GPs are friends for life with occupational therapy. They just started, they're just co-joined to us now. So I think asking them, how can we help? And being confident that it probably is what they're looking for.
Thank you, Shonaid. Absolutely, being helpful and asking how can we help you, I guess, to meet some of the gaps in your provision. Thank you so much, Shonaid. Alexis, you're next in the hot seat, please, for a sense of the development of your vision and how you went about changing hearts and minds.
So I think a lot of my experience echoes Alex and Shonaid as well. So I started working in a GP practice in North Wales that had become a managed practice. So the health board had come in there, and the health board actually used this as an opportunity to kind of explore a different vision of primary care. So they'd started looking at a model from Alaska called the NUCA model, which brought in a range of different professionals. And a very visionary OT colleague saw that they were looking at this model and saw that they actually had behaviorists. I can't remember the exact job title, and looked at it and said, actually, occupational therapists can do that and more. So we got an opening, and we got into this MDT model that was emerging. And then as we got into that practice, we looked at what the needs were. So we spent time with our colleagues. We were organized into little teams, and we had those discussions with our colleagues about where are the challenges? Where does this fit? So we started to find the gaps. We started to find the things that other professions were struggling with, and we came up with kind of 3 care pathways, essentially. So one around early intervention for mental health, one around frailty, and one around long-term self-management. Right. We started to implement them. And I cannot tell you how much I think what Alex has said about showing what we do is important. That was key for us. So we collected data, but really it was the GPs referring someone to us or asking us to see someone, and then that person coming back and saying, oh, I've done this, and they looked in the notes and they could see what we was done. And that was the thing that kind of really brought buy-in. And I was just going to share, I knew we'd made it when we went on a work night out, and one of the GPs said to me, I didn't understand why you were here in the first place, and now I refer to you all the time. And that was just a little moment of, yes, right, we're here to stay. So that's where we started and where we grew from.
Fantastic, Alexis. Thank you so much. Thank you for signposting us to the NUCA model. I'm confident that some links to resources will be available in the chat shortly. And thank you again for giving us those hooks: frailty, mental health, and self-management. Thank you so much. Di, I'll come to you for a sense of the development of your vision, please, and any tips for changing hearts and minds.
Yeah, so obviously I work in the policy sort of side, and the vision we work from is based on what we believe in as occupational therapists. You know what I mean? In that people have to be able to perform their occupations. The system wants to look at the whole person now. I mean, we're in a changing times with the demographic. People are getting older and living with long-term conditions, so it's moving away from that medical model. And I'm going to slightly embarrass my colleagues here when they talk about actually showing what they do. It's not showing; it's leadership. So all the OTs in Wales that have developed services are leaders. So you know what I mean? We are leaders in policy. So the doctors, we are not following the doctors. The doctors are following us, to be perfectly honest, because we are so embedded in what policy says in Wales and England and the rest of the United Kingdom. So my colleagues should be rightly proud of themselves. I think they sell themselves short when they say we demonstrate actually leadership, total leadership. And it'd be great if other colleagues follow that example. So I mean, the vision and leadership are connected.
Fantastic. Thank you, Di. And absolutely a round of applause, without a doubt, for you all, for the leadership that you're demonstrating. And thank you again for being here to help us learn from you and from your successes. But like we said in the introduction, I'm sure it's not been an easy journey. So we'll listen out as well for how we might overcome some of the stumbling blocks that I'm sure might be ahead for some of us equally on this journey. And Di, there's something that really struck me in your response, which is about the best visions and their relationship or focus on occupation, it being really central, of course, to our value and our identity. So thank you for those responses. Shonaid, I'm going to come to you for the first response to this next question. And I want to, I guess, get us to this sense of having the right teams around us, this idea that we need the right people with the right skills, competence, values, attitudes, all of that stuff really to help make vision a reality. And I'm really curious as to how you managed to build that team around you that you felt were the right people to support you in making the vision a reality.
Yeah, okay, so I think it's a wide team. It obviously staff, and I'll come to that. Your own team and staff. I think in the beginning it was Lisa and I, so the two of us. But I think we very early on we realised it was a partnership. So it was a partnership between us, OT staff, GPs, GP staff, definitely the patients, and definitely stakeholders and decision makers, commissioners, whatever you want to call them. So I think quite quickly, obviously Lisa and I were on board, singing from the same hymn sheet. GPs quickly got on board as we led them and showed them what we did. They started self-promoting between GPs and clusters and things like that. So very quickly we saw where there was definitely mileage in using them. One GP telling another GP is very, very powerful. We obviously had to look at support and critical friends around our own organisation. People who were buying into primary care redesign, people who were buying into trying to do things in a different way. There was an appetite for early intervention prevention, but obviously hands tied with what's still happening at the very acute coalface. Yeah. Where do we shift money around and that type of thing? It always comes back to money. Certainly my own professional lead very much was part of that team to help with the vision and keep me going at the times when it was really quite tough. We've got a primary care occupational therapy network in Scotland. That was really essential as well. We're all at different stages. Some of us are much further on than others. Some people are just beginning the primary care journey, but that's been a real source. So that bigger network. I think very quickly on, our patients became our biggest advocates, without doubt. And we've broached, we sort of touched on that, talking about them coming back and telling the GP how good that was, how great it is, what a different life they're now living, etc. They were telling their friends, telling their families. I had one lady that once said to me once, and I'd never thought about this before, really, you've not just helped me, you've helped 5 other people, because my husband and my 3 children did not know how to live with me anymore. Wow. So that's really, it was kind of, wow, for every one person you see, maybe there's another 6 people that lives have changed. So and we don't count that in any way. So that was a really lovely sort of feedback. So patient feedback. We've got Care Opinion in Scotland, where people put on their sort of web-based, they go in and put sort of how they found the service, what was good about it. We've got over 100 of them, and they have been so instrumental in being able to just demonstrate what a difference this is making for patients. And I suppose as we've rolled out from 2 OTs, at the moment we're sitting at 27 of a staff, and we are recruiting up to 40 over the next wee while. Our biggest asset is our team, our staff, and I think we thought a lot about recruitment going forward. How do you get that bigger team on board? How do you get people who are really interested in primary care? We did, for the first time in my experience, I did a big recruitment drive. We did a lot of advertising around it. We did recruitment sessions. We did online sessions. We wanted people to really know what they were coming to. What team were they kind of going to be coming to? Did they have the same values and knowledge and skill set that we wanted, or were willing to work towards that skill set, because nobody comes into primary care with the skill set you need. So I think with our new team that we've got now fairly new in place, that the newest recruits are sort of 3 months in, we're beginning to reap the rewards of that, I would say.
Amazing, thank you, Shonaid. And can I just understand who's in your team? What sort of professionals, I guess, what sort of professional groups are represented in your team?
It's all occupational therapy. So
Amazing.
It's not occupational therapy, but it's a skill mix, so it's band 5, 6s and 7s.
Awesome. Thank you so much, Shonaid. Next, I have Alex, and a similar question for you. How did you build, I guess, the right team to help realise your vision?
So, as I said, it started as a lone prac in income TAF as a band 7 in that role. And probably within about 6 months or so, 6 months to a year, they said, we need more of you. And I said, you don't need more of me. You need more of something to do with OT, but not necessarily more of me. And by that, what I meant was I was trying to kind of promote the band 6 roles, I think more so within that setting. We needed more clinical time on the ground, and maybe as it was evolving and developing, it felt like my clinical time was being eaten into more so with development and strategic direction and things like that. So when we set out to recruit OTs into primary care, we had one advert out for band 6. Such was the quality of 3 applicants, we appointed all 3. And that was a massive blessing from the primary care director at the time. But that was also largely based upon the belief that this model could grow and develop, and we didn't want to miss out on really fantastic candidates at that time that might go elsewhere. We asked an awful lot of value-based questions within those interviews, really, just to really dig down into kind of that OT ethos, if you like, and knowing that in primary care, it's probably as much about the personality type within it and working within that forum that can be quite difficult, quite challenging at times, particularly in GP practices, especially the ones that are the private businesses as well. We utilised the employ to deploy model, which we have in Wales, which sounds similar to like the ARR model in England. So basically looking to protect people's terms and conditions. So clusters, we don't support clusters appointing directly OTs in Wales at this moment in time, which also just allows us to keep that governance structure in place, access to things like our joint equipment contracts and things like that. Because if OTs can't access equipment, then, you know, obviously that's a big no-no for us. Also, students become a big part as well, so that we're trying to kind of promote our role for the future kind of workforce that are coming out as well, so that they're thinking about primary care as an option and an offer as well. And I've done talks at some of the Cardiff University have invited me in on a couple of occasions to do a talk around some case studies and things like that that they're doing. In terms of the wider people, so beyond just OT, I think that bit just requires time, perseverance, patience, and, you know, just sheer hard will, really. Because there's so many stakeholders to consider. I remember being in that role by myself, thinking I've got the GP practice here, I've got my OT management, I've got the primary care directorate manager, and there was so many different people with different asks and different wants from it, and they didn't really necessarily link up in the way that you would hope they would. So I had to work really hard, basically, over those, having a cuppa, because I was in the practice. It did help, I gotta be honest. Being in the practice and being able to have those conversations definitely helped. But what you realize quickly is each person will give you a unique perspective on what drives them and what drives their services as well, and what they need to see from you. And as OTs, I think we're really well versed in making sense of an awful lot of information, trying to combine it together to kind of realize that you can present this almost unique joined up approach and vision that meets the needs of an awful lot of people. And pleases an awful lot of stakeholders, because actually a lot of the time it's the same information that we're providing. We're just sometimes presenting it in a different way depending on the forum that we're within.
Excellent, thank you. I've already started to make a list of some of the tips that have been emerging from your answers, and I'll reflect them back to you all before we move on to the next question. But I'm going to come to Di next. Di, in terms of, I guess, from a policy perspective, how might we go about making sure that we've got the right people around us to help realise this vision?
Yes, it's really interesting, and again, I'm going to say about my colleagues and how fantastic they are. It's that understanding of population needs that we do really well. So what Alex talked about, actually we look at the whole person. It's not just the whole person, it's like what's happening in this cluster, what's happening in my environment, and then models sort of develop in relation to that. This is why we've got slightly different models throughout Wales, because our OTs have identified an opportunity with a particular population and then exploited it for the benefit of the patient. So in North Wales, it's more mental health focused. In South Wales, it's more frailty focus, and actually in Wales now there's only one area where we don't have OTs embedded in clusters. So I can see it's our OTs and they're really good skills at actually identifying a population needs. Also as well, I think as a profession we've got to look like now, how do we move this on? How do we increase placement capacity at primary care? And how do we work with our partners to really embed these services? So fragility of funding is still a major problem. A lot of our OT pilots are still funded on quite short-term funding mechanisms. So I think if we want to increase that MDT, we've really got to work hard in ensuring that innovative funding turns into mainstream funding. And I think that's the next stage of getting a proper team in clusters and GP surgeries.
Yeah. Awesome. And I'm really enjoying that we're building really nicely onto perhaps some of the barriers systemically that we might need to address in order to really make this, or the adoption of occupational therapists in primary care, a lot more widespread. But before we go there, Alexis, I'll come to you for your view on how to have the right people around you to realise the vision.
So I was going to agree with a lot of what's already been said in essence. So you know, we have some phenomenal members of staff who've come in and really shown what OT can do in primary care. And actually, I'm very pleased that we've now got a rotational post that comes into primary care as well. So thinking about developing that future. The thing I was really going to advocate for though is, actually, I was thinking about two things. So one is I've had some amazing help from some project managers who've really supported me with some of my data collection and how I can do that. And I don't have that so much anymore, but actually that was really, really helpful in getting things off the ground. The other thing I was really going to advocate for, and I think this has kind of come into other people's answers, but I'm going to push it a little bit, is really thinking about the strategic leadership in your health boards. So, you know, as you've hinted at, we have faced challenges, and when those challenges have come, as I've communicated my vision and what we're doing and the outcomes we're achieving, the relationships I've built on a strategic level with some of the therapy leaders, so they know that vision, they know why we are doing it in the direction of travel, and then that links to the strategic direction that's set by legislation as well. So, you know, I was thinking about something around where you need to know your audience and you need to know what matters to them. And I think, again, that's been mentioned, but I really just want to highlight that. You understanding what is important to the individual in front of you, building those alliances and showing that strategic direction and how it fits into that. So you then get your strategic leaders on board.
Amazing. Thank you so much, Alexis. I just want to reflect back what I've heard so far, and perhaps I'll invite some of you to come in case I've missed anything. But for those of us in the audience who are looking or who have a vision to embed occupational therapy in primary care and looking to get a sense of how you can realise that vision, here are some tips from our brilliant leaders. Create advocates who can do the advocacy work for you. Ask value-based questions in your recruitment. Offer placements so that our budding occupational therapists can also have exposure for what the role of occupational therapy in primary care can look like. You might need some time, perseverance, patience, sheer determination and will. Really loved that. Take a population health approach, introduce rotational posts, use or draw on your project management support and help and functions around you, and certainly start to influence your strategic leaders through fruitful and constructive relationships. I wondered if anybody had anything to add. Alex, I'll come to you.
Yeah, in my waffly answer before, I missed out some key bits. I think it's really important that you do look at your modelling and you design that modelling around what your need is. So, for instance, come to half, we looked at how were we going to achieve full population coverage? What did we need? So we decided we needed a band 7, a band 6, and a band 4 per roughly 60 to 80k population. So our cluster split really. The band 4s were generic posts between physio and OT, and they were just so amazing and so valuable at kind of taking on a huge amount of additional work that saved an awful lot of time for the registered staff that didn't necessarily need to go out when we already had this wonderful skill set with our unregistered cohort in the team. So I do think that's really important to consider as well. I think that was the main point I wanted to come back to, is just remembering that obviously we've got our registered staff like our 7, 6s and 5s, but those band 4s are invaluable to actually growing a service and being able to provide the full breadth of what we need to do.
Yeah, and a really important point, I think, to bring to the forefront of our consciousness, Alex. Thank you so much for doing that. Absolutely. Liberating our support workforce only liberates us and our potential as registered professionals to be able to focus our energies into other parts of the system that I guess draw on our skill set and competencies better. So thank you so much. I'd like to move the conversation on to outcomes or outcome measures, or better said, impact measures. And I'm particularly curious to understand what outcomes you all looked out for. How did you, and we've started again to build on this. Alexis, you made a lovely point around how did you know success was coming or was there? But what are the types of outcomes you looked out for, and which did you find most useful to collect? And I'll start with you, Alexis, please.
This is I could go on about this for ages, so please forgive me and tell me to stop. The first thing I'd say is the first thing I want to say about this is you will not end up collecting what you started collecting. So we started really small. So when I was working in practice as a first contact OT, we started just looking at repeat attendances, if people were coming back after they'd seen us. And once you start to collect data, once you start thinking about what you need, you also start to understand where your gaps are. And so you start to build up this nuance of data as you go forward, and you start to understand as well, because you start having conversations about it, what means things to other people. So once you've got something you can start to talk about and work through, that helps you shape where you're going. And I think that's really, really important. And I think it helps you understand the impact you're making. Something I was thinking about in the last question, I'm thinking about it here as well, is I think we're really bashful sometimes around the impacts that we make. I think part of that communication with some of those stakeholders, with the strategic direction, actually, as a profession, I think we probably need to be more confident in the difference we make to people's lives. And then we can share that. And I think we perhaps do that in a way that others professions don't. I think it's because we do complex intervention, multifactorial complex interventions, and that's hard to measure. It's hard to fit into the kind of evidence-based collection that is often used in healthcare. And I think we need to be more innovative and more confident in collecting data. Interesting, because going from presenting a lot of kind of quantitative data, how many people have we seen, how many interventions have we delivered, and I've been presenting those to the clusters, and they've started coming back to me and saying, oh, we know all this data, we know how many people you're seeing, tell us their stories, tell us the impact that you're making, tell us, because we know you're working with people who are complicated, we know you're working with people who are in distress, and actually we want to understand those kind of stories, because that's what helps us understand the work you're doing. And that's been really great. So a joyful thing in my life, I was at a conference last week and they were talking about bringing joy back into primary care. A joyful thing in my life is when I see my prems coming in and I see the comments where people are saying, this has really made a difference to me, or I'm going to keep using this into the future. So, and then I've got the confidence to go and take that to the others and say, look at what we're doing. So that's great. I don't know if that answers the question. I could ramble for ages about this.
That is a fantastic ramble. You're always invited to ramble, Alexis. Thank you. So what I got from that is start somewhere, start collecting, and as you go through the process, you will refine naturally the value of what it is that you're collecting, but absolutely become very aware of the gaps, and that might then change the direction of what it is you're collecting. Consider qualitative as well as quantitative outcome measures. I also heard very strongly there with that invitation from your colleagues around telling stories, and to be bold and to think creatively about the different ways that we can start to measure but also communicate our impact. Thank you so much for that, Alexis. Shonaid, I'm going to come to you, please, for a sense of the outcomes or outcome measures that you were looking out for.
Okay. So I think in Scotland, talking to my colleagues across primary care who are starting out or a bit further on like ourselves, our outcomes quite often are determined by our funding streams. So our money came from primary care improvement. Other places, money's maybe come from moving around some money around frailty, vocational rehab, or mental health, or whatever. So that kind of determines how that service grows, which then determines outcomes that people are looking for. Because obviously your money came from falls and frailty, you're looking around falls outcomes and what have you. Initially, our only instruction, I suppose, at the beginning was, could we demonstrate that our impact had an impact for the GPs and that patients returned less often? So pre-appointment, post-appointment counts of before an occupational therapy intervention, which seems like a good idea to do. It's quite hard to do, but we did do it. But it also seemed like a missed opportunity because as OTs we really wanted to see, not only did they come back to the GP's less often, but it didn't get any better for them. And I suppose you could argue by coming back to the GP less, maybe something did, but we wanted to really, sort of get more information around that. So we wanted to know, was their function better? Was their lives better? We had to pick two, not just like the hat. We used COP and we used WenWeb. We just wanted something that would could be held up against every patient, and because there's so many outcomes out there, so we plumped for those two. So we had a sort of occupational therapy based one and a general sort of wellbeing and health one. So we did that. We did that phase 1. Phase 2, we also started looking at things like cost avoidance. So looking at patients that we'd seen that maybe that prevented them going on and needing home care, or antidepressants or pain reliefs, maintaining work, returning to work, to try and show cost savings across the whole system. And we got some help with that from public health, so that was really useful. Quantitative data, patient stories, and we've got an outside researcher to come in and do qualitative interviews with patients as well, write that up independently. That was really useful because it wasn't seen to be us doing that, so that was helpful. But the patient stories and patient videos, patient feedback, things like that are very they're good, strong evidence when you're trying to get your story across, maybe perhaps in a presentation and what have you. So that's been invaluable for us. I think I'll just quickly add on here, one of the mechanisms we used around our whole projects was quality improvement methodology, and that just helped underpin everything we did. That whole sort of process of thinking about what we were doing, what we were changing, what were our measures, what were our balance measures, what were our outcomes, how to display that, and that gave us a real voice when we were presenting our data and presenting our evaluation and outcomes. That we had a fairly, it wasn't researched, but it was a fairly robust mechanism, a well-respected mechanism in I have to say, in NHS Scotland, and that I think probably added some weight to what we were able to present.
Fantastic. Thank you, Shonaid. That's incredibly helpful and pragmatic answer, because I think it is really important for us to remember that funding will sometimes absolutely determine the outcomes that you do need to gather or stipulate what your outcome measures are. And what you've done there is named some standardized but also some non-standardized outcome measures. The COPM and the WEMWB, for those of who might have missed, those are some of the ones that Shonaid has mentioned there. And you also mentioned some really important methodologies. So having some independent people, a less standardized way, but having somebody independent, I guess, to also review the outcomes and then create a synthesis from that data, and QI methodology. Always a really useful tool or different way, to start to collect impact measures. Thank you, Shonaid. Di, I'm going to come to you, please, for an answer to this question around measuring outcomes and perhaps any recommendations, certainly with a policy lens too.
Yeah, leadership again, I think, especially what Alexis was saying, actually how outcomes change as you get into the service. So it's a lot of our pilots in Wales, obviously they've got to do the outcomes in relation to the funding, but they try and improve the case in relationship to what the GP might want. So that is reduced attendance, stopping people coming to the surgery. But as it morphs then, as the GPs can actually see the complexity that we deal with, they want them sort of outcomes in, because that's what meets the requirements and the legislation about dealing with complexity, understanding that sort of system. So you can see how it morphs as we get the services embedded. So that is like really interesting, I think, you know what I mean? And don't be shy to proving your worth in relation to we're occupational therapists, so Shonaid's focus on that is really important. So it's interesting to see the journey and what we prove. First of all, we prove to the GPs actually we can do all this that improves the process, and then the GPs see us what we can do for the patient, then we start proving the quality of our interventions towards the patient then. So that's really interesting. So don't be afraid to prove our core core beliefs in occupation.
Thank you so much, Di. I'm really enjoying the bold invitations that you're putting to us as a profession to be less bashful, to really own our occupational therapy identity and remain true, I guess, to what our contribution is. Some really helpful suggestions there around how you might start to understand the types of outcomes that you might need to measure, trying to understand, certainly from a finance perspective, because let's face it, money does talk sometimes, understanding who gets what, who owns what, who does what, and who's affected by the thing it is that we're trying to do, the change that we're trying to make. I'd like to come to Alex for your answer, and I'll come back to the panel because I'm conscious there's been some really interesting conversation about this and some questions from the audience as well. So Alex, just a sense of from you around outcome and impact measures, please.
Okay, so let's forget the fact that I started with nothing and had to backward chain. Alexis and Shonaid are completely underselling what they've done and how inspirational they are in terms of outcomes and the way that they've looked at things. Yeah. So I think I can only echo that data capture is absolutely key, and being open to it evolving and changing as we evolve and change within that service. I think figuring out what your tangibles are is a really key message for your GPs, and providing context within that. So if we think about our pharmacy colleagues, for instance, in GP practices, it's really easy to give a tangible from the point of view of, we'll do this many med reviews for you, and it saves an awful lot of time for the GPs, knowing that those med reviews are managed, or some of those chronic condition registers are being managed by pharmacy. So we have to be good at selling ourselves differently, that our tangibles might not be as obvious at that first phase, but actually how are we impacting that journey longer term over that course of that patient journey that's managing their health conditions as well. So I remember lots of conversations with GPs, because they work in obviously sessional times around 10-minute slots and things like that. So saying that, oh, well, we've done 4 visits today doesn't sound like a lot, but actually, because we are engaging holistically with someone and kind of trying to look at the whole picture and put a plan in place that's co-produced with that individual for the longer term management, so they're not returning back to the GP, that is a time consuming process, and it's a very worthwhile process. And they start to see that through these repeat attenders maybe not coming back. So anything you can do that's maybe outside of the standardized approach is really valuable as well. Do case studies, do patient stories, do all of these sorts of things that go outside of your normal prems that you might capture. So for instance, I've got a data capture around AusTOMS, the Australian Therapy Outcome Measure, for a standardized measure. We do a prems, which is just a quick survey. And then I've got a database which captures all of the interventions that we do, the onward referrals that we do. You know, it gives a bit more meaning to kind of what's behind our interventions, because ultimately we can present an AusTOMS in the majority of forms and it's meaningless to the majority of people unless we give context behind what does functional change mean. What does a 1-point change mean for someone's journey? If we sell it as 1 point, does it sound a lot, or do we say 20% change for someone in their functional level? It's a completely different way of representing data. We've got to be really thoughtful, I guess, about how we do that. My last point really is, well, the last 2 points I got is be ready to also contribute to MDT outcomes. So those of you that do sit within MDTs, be part of it, give your voice over as well, so that we've got our standalone contributions, but you know, I don't like the EQ5DL. That's my honest opinion. Okay. But Welsh Government really buy into the EQ5DL and they understand it. So if an MDT is doing it, I'm going to do it because I want that voice heard. It doesn't matter about personal preference for some of these things. There are no perfect outcome measures ultimately. So it is about trying to find the things that fit best within the service that you're doing and presenting them in the way that you want to present them, and not being hamstrung by necessarily those limitations. And I just want to share something personal really, because even this morning, Christine, who did the talk with the pre-recorded talk with me this morning, sent me an email from one of the cluster business managers, just basically talking about how they're tightening up on data collection from clusters in our health board. he said, but you don't need to worry because you're always hot on providing us with data, so much so that we've recommended your service goes forward for long-term funding and moves away from cluster funding model. And
Wow.
I just wanted to quote him, really. And he said, the reason I mentioned the OT project for central funding was because you have provided so much evidence over the last year or so to back it up. And I just think that just shows, doesn't it, that it's a real multifaceted approach that we've taken in all of the reporting that we do. And we're consistent across our service, regardless of whether it's virtual ward or the cluster, the models, so that we can continue to demonstrate it. And it's live data, so it's there, it's ready to go. I don't need to spend hours pulling it from different sources and compiling it and everything else. So it's just those elements to things as well. I just think it's really are really useful to share. And if anyone wants to touch base about anything, then like I said, I'm not the best person on this panel by a long way about outcomes, but I'm willing to share anything if it helps.
Amazing. Thank you, Alex. And so humble there. I mean, you've just shared an absolutely phenomenal sort of impact story from the work that you've done. And you can see colleagues celebrating you and congratulating you. So absolutely well done. Well done on behalf of the profession too. And thank you for sharing. And absolutely, I'm sure there's many people who'll take you up on that offer to connect with you and learn from you. Something really powerful in your response there that I just want to reflect back, which is about data is absolute. Yes, it's key, but actually data is a tool. And like with many tools, it's all about how you use the tool that really leads to the best outcomes. So perhaps there, that point about not so much being stuck on the data tool itself or the data, but actually it's about what does the data tell you? What is the story that the data is conveying? And I just want to, again, you mentioned the EQ5D, which is a quality of life outcome measure. For those, again, if there is anybody in the audience who's listening out for particular outcome measures. But fantastic share there, Alex. Thank you so much. So Alexis, I've heard that maybe you've sold yourself a little bit short. So I'm going to put you back in the hot seat really to tell us more about the awesome stuff you've been doing.
Well, in that case, I'm going to go with an absolutely shameless plug and say that
please.
I'm presenting all the data that we've pulled out of our project in the next session. So if you wanted to come along to that and hear a bit more about it and ask any questions, then that would be brilliant. And I actually did want to pick up on another point as well, which I think was made earlier, was also that mix of outcome measures. So we're using the OSTOMS as a therapy outcome measure, but we're using the REQUAL 10 as a more generic one. And I think, but also one that I think fits really well with therapies, particularly, occupational therapy, particularly working in mental health. So just a quick citing of that outcome measure as well, if you want to have a look at it. It's really quick and easy to use.
Super stuff. Thank you, Alexis. And when's your session? When are you presenting next for us to join?
Next, I have to go from this and then join that one, so it's pretty immediate, I think.
Okay. Well, we are 9 minutes to end, and we'll make sure we finish on time so that you can start that session and absolutely join you in the audience there. So our final question, I guess, for you all, and I'm going to start with you, Alex. What's been the hardest thing? Because I'm sure it's not been an easy ride, and there's been some tough things and moments that made you go, whew. So what were those like, and how did you overcome them?
Fragility of funding is the obvious and the big one. A lot of our roles were funded from a transformational budget to start with. They were done on a permanent at-risk basis within our health board, but then there's no contingency plans for when people left. There was no contingency plan also for COVID hitting, which was obviously probably ravaged an awful lot of services. So it changed perspectives within my team, because I had some staff who were originally from Ireland or West Wales or places like that. So naturally, I understand it. They wanted to move closer to home. They had spent a long periods of time not being able to see their family because of the pandemic. But the problem was, when they left, we weren't able to fill them because the primary care monies were reallocated towards like testing centres and everything else for that. So unfortunately, fragility of funding beyond just COVID is a consistent picture across Wales, really, and has been, where we've had amazing pilots that have achieved wonderful things. But when it's come to the crux of, does this pilot continue? Where's the funding coming from? That's when it's fallen by the wayside.
Yeah, and I'm sure colleagues across other nations probably identify with that, or that resonates with them too. So Shonaid, I'm going to come to you, I guess, for a sense of what's been the harder things over in Scotland.
Funding. funding. Yeah, funding. But what I would say, we knew from the beginning that funding was tough. We knew from the beginning we were only just got our feet in the door. People weren't really sure what it was about. It was a small amount of money. What harm could we do? We knew that we would do well. We knew that we'd show good outcomes. We knew occupational therapy was right to be in primary care, and Lisa and I knew that we could demonstrate that. So we knew from day one that funding was going to be hard, and we never let it put it off. Let it put us off, is what I'm trying to say, because we just kept going, collecting data, and if we hadn't had all that data at the end, when the money actually came, we wouldn't have had the data, and we wouldn't have had the stories and the patients and the GP buy-in and all of that stuff. So the two things coming together did. So I would say to people, don't be put off about the funding. Having said that, I know it's really hard. I had 18 months where just some days I didn't know why I was still doing this job, to be honest, but kept going, and that's where you go to your support networks, and that all really worked. I suppose right now, two sort of other problems other than funding. One is just around infrastructure. Primary care is quite hard to work in. Accommodation, IT systems, none of them talk to each other. Working remotely is quite difficult in Scotland. Vision Anywhere, Vision 360, these systems that kind of talk, don't talk. The logistics around that, as we build more staff, is really difficult. Accommodation is really difficult. There's not space. You're trying to do a call line model, but there's no space in the GP practice. And that's fine for doing some of near me and telephone consultations, but you've got to be in people's localities if you want to do face-to-face. So we don't want to lose sight of our offer and our model and our service delivery by moving too far away from the actual locality. So that's a real challenge. And the other challenge that is quite apparent to us now is the workforce. So we have a fabulous set of staff that have joined us. I would say their values are totally aligned with what we're looking for in primary care, but our knowledge and skills across primary care, because we are a mental health and primary and physical health service, it's going to take time for that workforce to get up to speed. We know that, and we have a number of measures in place to support that around skills and development, robust supervision structures, robust triaging, training development, all the usual mechanisms, but it will still take time for some of those new staff to become competent and feel competent within primary care. So I suppose the challenge is, how do we maybe go a bit more upstream with that, with bringing occupational therapists, I don't know, looking at what skills, wider skills we maybe need in primary care. We do take students.
You might add, and then Alexis.
Sure. I only just wanted to focus on one quick solution. Well, obviously we've already mentioned data, but another really key solution is Di Davies in Wales for us. He had no idea I was going to say any of this because I didn't say it in kind of the pre-conference discussions, but he has a different reach. So RCOT do have a different reach, and it's about engaging with them, because for Di, he brilliantly connects what's happening on the ground to the political landscape and advocates for us. There's only one slight issue that I've got, and that's a big plea to RCOT really, is that we need more Di, or we need more support for Di to continue doing what he's doing, because obviously he's brilliant for primary care, but he's also trying to be brilliant for everything else as well. So we need more Di, and then a lot more solutions will kind of come.
Love that. Thank you so much, Alex. And Di, that's your little moment to be a little bit embarrassed, if that's okay. I'm going to come to Alexis for your sense of what's been hard and what we might do to overcome those, please, Alexis.
Well, I was just going to give Di some applause as well, actually, because there was two things. I've got two things. I'm just going to run. One was a very quick one. I think sometimes it's the communication about, we're trying to make complex systems change, and not everyone will get on board with that right from the beginning. It can be hard to communicate, it can be hard to share those impacts, and Di has certainly been a support for me in that kind of process. So really just to support what Alex has said. The other thing I wanted to reflect on, and this is more of a clinical one actually, is that there's a challenge about, we're sitting in a different place in primary care. And what I mean by that is, I come from a background of working in acute mental health, forensic, locked mental health units I've been working in. And it's a very different thing to sit alongside someone in primary care. In lots of secondary care settings, our settings are slightly coercive. People will do stuff because they want to leave, they want to go home. And I think that's probably fairly universally true. in primary care, that person will walk out the room, and whether they choose to do that thing you've discussed with them or not is completely down to them. And actually, that's really liberating when you get your head around it. It can take a little while to get your head around it. It can be quite scary, actually, as well, because also you're dealing with people coming in with all kinds of different problems. You're trying to fix them for them. Actually, no, it's kind of letting go a little bit, letting that person working truly with that person. And actually, that can be really nice when you get to that point, or when you find that balance. And a lot of my colleagues have told me that coming and working into primary care, they feel like proper OTs again. They feel like they're sitting, working with that person holistically, and it is a truly shared plan. But I think a lot of the time we're so used to working in settings that are either directly coercive, like locked mental health rehab units, or like, hospital settings where the desire is just to get home. And I think actually reflecting on that difference as you move into primary care is quite an interesting thing to do.
I love that. Thank you all so much. I absolutely could continue this conversation for so much more, and how delightful that we have Alexis's session that we can parachute straight into after this. But I'll leave us with some closing tips for anybody in the audience who can also help us make this vision a reality for occupational therapy. And that vision is to embed occupational therapy in primary care settings. We need more stable funding, please. We absolutely need the infrastructure to support our embedding within primary care settings. We absolutely need to retain the existing primary care workforce. We've worked really hard, as you guys have, to attract people into primary care settings. We now need to keep them there, and absolutely some more student placements to stimulate and inspire the budding occupational therapy workforce to work within primary care. And remember our core value and contribution. Thank you all so much for joining today's session. Thank you to our brilliant panelists. Thank you to the audience for being here with us, and absolutely thank you to Jen. I wish you all a fantastic rest of conference, and have a great rest of day. Take care. Bye-bye.